Welcome everyone to today's webinar. It takes a community bringing stakeholders together to increase EHR adoption and utilization. I'm Brian Zimmerman, the Custom Content Editor with Becker's Hospital Review. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log in to today's webinar to access the recording. At this time, I'm pleased to introduce our two fantastic speakers from Allscripts, Dr. Salman Naqvi, Clinical Practice Leader in CMIO, and Allison Aaron, Assistant Vice President, Professional Services Sales. With that, I'll turn the floor over to Allison to begin today's presentation.
Excellent, Brian. Thank you and good morning. Thank you to Brian and Emma and the entire Becker's team for having us. Dr. Naqvi and I are pleased to be here. We're excited to spend some time today talking to all of you about EHR adoption and utilization and really what that means in our industry, how that shifted maybe since the inception of EHRs years ago, and what that means for us currently and for our future. So we'll spend some time talking about the foundational elements for EHR and utilization, talk about the difference between a vendor relationship and a vendor partnership and how that's incredibly important. And then perhaps most importantly, talking about your strategic goals of your organization and how those drive the outcomes that you intend to achieve both within your IT space and throughout your entire healthcare organization. So we'll get started by talking a little bit about the landscape in which we exist today. We are in a space where organizations are experiencing increasingly complex infrastructures. We're being forced to meet industry demands. We're forced to do more with less. And it's becoming increasingly difficult to maintain focus on both the importance of an IT infrastructure as well as the clinical quality and outcomes that are important and are supported by an EHR partnership. And so one of the things that we talk a lot about is where to begin in the beginning. And if you're beginning with the end in mind, you have outcomes in mind for where you want to end up. So when we talk about building adoption and utilization within the organization, it's important to understand the goals for quality and safety and satisfaction. Many of you probably live and exist in a bridge between an IT space and a clinical space, and working to develop that partnership between also includes developing the partnership with an EHR vendor partner to achieve success in those outcomes. Oftentimes we're struggling to translate what the system goals are within the organization to the individual gains, and that might be through clinical quality scores. It could be through shared savings models, through ACOs and otherwise. And we still have to pay attention to the needs of the organization. Oftentimes we all know that the people who knock on our door or fill our inbox or shout the loudest get the attention. So how do we meet the needs of our team while also meeting the needs of the communities that we care for and building the relationships within the organization and partners to be successful? And then finally, how do we look at our EHR vendors as a partner? Oftentimes, I think there's a box around EHR vendors that is one where you provide a technology, or you provide a help desk, or you provide a service or an outsourcing staff. But truly, if we start looking at the outcomes that are important throughout your organization, the EHR vendor becomes a partner to help you achieve those outcomes. So I'm going to let Dr. Naqvi talk for a few minutes about the goals between the IT team and the clinical team and how we find a space to exist in between to find successful outcomes across them.
Thank you, Allison. Good morning, everyone, and thank you, Brian, for inviting us to this presentation. Just as a quick intro, I'm a CMIO for Allscripts. I've been here for about 15 years. Even today, I'm at a hospital where we're talking about exactly the same sort of things, doing adoption and success work as opposed to pure EHR implementation. And I think I'll piggyback on Allison's comments so far. the technology has become a lot more smarter in recent past. It has also become a little bit more diverse. It is able to answer a lot more questions than it could maybe 4 or 5 years ago. So from an IT team's point of view, moving to this modern technology is absolutely helpful in achieving the objectives that we talked about earlier, which is quality and safety and translating system goals to individual goals, et cetera. There is better infrastructure not in terms of just the applications themselves, but in terms of network and hardware and hosting and security applications that are available, or the infrastructure that's available to make sure that you're working in a safe, reliable environment. And there are organizations which are, more independent now because of the technology that they have in sort of driving towards their locally creative solutions, whether it's modifying their workflows to meet changes in the scope of services they provide in the health system, or so on and so forth. At the same time, the change in all of this infrastructure or new technologies or new applications, it's also not always efficient on day one. We still have organizations that struggle with finding the right balance between the IT staff that they have working on existing applications and dedicating their time as the organizations try to move towards newer solutions, and what's the right balance of training and education for their IT teams. That's always something that we observe in our clients. We're always still, even after meaningful use, looking at organizations that are playing regulatory catch-up, and that means that whether it's within a certain scope, within a hospital or ambulatory setting or an outpatient service, regulatory work still continues to consume a lot of resources from IT organizations, and a lot of the leaders in healthcare systems are looking at CIOs and the IT organizations to deliver that return on investment that they asked for when they asked to switch to a modern infrastructure. Now, both of those do happen where, as a vendor, we tend to see a lot of that conversation when we interact with our clients or on the hospitals that we work for. But there's not necessarily just that group of individuals that we're interacting with. When we're interacting with the clinical teams, or at least are exposed to the clinical teams via the IT teams, they have their own challenges as organizations are going through newer EHR adoption or utilization of newer applications. And clinicians are now more accepting of newer technology. They find the value. They have already graduated through a wave of EMRs where there's no more an organization where we are going in and saying, oh, we have to replace paper processes. We're replacing older, more archaic EMR processes with newer, slicker EMR processes, and clinicians are ready for that. They are also, more excited about things that they can do on mobile apps, things that they can do because there are greater uptimes because of all this reliable technology. They feel like that they're in a much more stable place, and stability is very important to the clinical teams. And over a period of time, they expect less and less change in their workflows as these technologies get mature. But on the other hand, we still continue to hear a lot about too much documentation. And along with that, with the maturity of EMRs or EHR applications across the enterprise, there's a slow erosion of the niche applications that were specifically built for one department or another. And so a lot of times, there's an acute sense of loss when people move from a very niche system that was built in-house or built in close collaboration with a specialty EHR team, and to move to an enterprise team, which may have some benefits for connectivity, but it may still have some trade-offs with respect to some customized functionality. And change is still disruptive. Every time there are upgrades, every time there's new implementations, every time new modules are added, it doesn't matter how helpful they are to the patients and to the providers, there's still a time of disruption, which sort of makes people a little weary of change within large or small healthcare organizations. Allison, I don't know if you wanted to talk why, we're still focused so much on adoption and utilization in this day and age.
Yeah, absolutely. One of the things we talk a lot about is adoption and utilization and when that begins. And we believe that it begins before day one ever starts. When you're talking about the goals of your organization as you're looking to select a vendor partner for your EHR space, or you're looking to further develop the relationship that you have with your current partner, it's really important to be completely in line with the goals of the organization. In my position, I get to work with all of our clients across the U.S. and have really interesting conversations about the level of adoption and the levers that those organizations are pulling to help increase utilization and adoption. It will be no surprise to all of you that there are studies and research that shows that as adoption and utilization increases, so does the relationship with HIMSS stage achievement. So what that means is the higher the HIMSS level of an organization directly reflects the level of utilization and adoption within that organization. It's been really interesting to have conversations with our partners and our clients who have achieved stage 7. It's an incredible accomplishment. For those of you that are on the call today, congratulations if you've achieved stage 7 or you're on your way. There's a lot of hard work that goes into it. And one of the things that we talk a lot about is why that's important and how your partner should help you to achieve that. So when we're talking to clients and we have the conversation, certainly if it is a new implementation of an EHR, we are incredibly proud of and excited to talk to clients that when they go live on an EHR application, they'll go live with us at stage 6, and we support them to get to stage 7. That's an incredibly important part of a vendor relationship. One of the things that we spend a lot of time talking to clients about is what exactly are services? We talk a lot in our industry about services. We talk about EHR as a service. We talk about staffing as a service, consulting as a service. And what does that mean? In our industry, over the last 7 to 10 years, there's been a significant shift in why EHRs are important or required in healthcare. In the beginning, it was to meet a lot of rules and regulations, to check boxes, to be able to connect patients and their data within a healthcare organization. Now, that's spreading outside of the walls of an organization and spreading out into the communities that you serve. When we talk about services, it really falls into 2 buckets to help strengthen an ultimate vendor partnership. One is the traditional services that are required to implement or install or upgrade your software. So whatever software you're using, you have to upgrade it to meet regulatory requirements. You may expand it to increase feature functionality. There are services that are required to make that work. In the second bucket of services, you have the ones that are more value-added or consultative in nature. And this is where this HIMSS service enters the picture. So when you're looking at the importance of utilization or adoption, you're connecting that to the level of service as you're building your EHR vendor partnership. Certainly keep in mind the relationship of these HIMSS analytics and MRAM, whether it's in the inpatient or the outpatient space, and the achievements there and how your EHR vendor can help to support that. So now let's talk about the things to look for in your EHR. So everyone on this call is using an EHR today. Maybe not everywhere. There may be a few pieces of paper that are still floating around in some business, in some departments of the hospital or clinics in your ambulatory space. But there's a lot of things that are important to look for as you're strengthening that EHR relationship or as you're looking for a future partner in the EHR space. One is certainly, from a technical perspective, the modern architecture. So what is the platform that you can easily build on and easily expand on? Is that an open, modern architecture that allows for the openness to connect to other innovative partners in the industry? Oftentimes, older technology can perform similar tasks, and it may meet the needs of today, but future upgrades, future expansions, future partnerships might be cost prohibitive when you're not on a modern architecture. So that's number one, incredibly important. The second is data liquidity. having a single database that makes it easy to access and report on the data from your organization. All of you would say that you have a ton of data in your EHR. I was talking to one of our partners and clients last week, and they said, I have so much data, I don't even know what to do with it. And we started talking about the analytics and what that means and how they can use the data that they have, formatted and extracted in a different way to help them drive things like clinical quality scores and improvement. So you have the data. If it's in a single place, it makes it easier to aggregate and to analyze and to meet the needs and objectives of the organization. Thirdly, it's critical to have that trusted vendor partnership. So we talked about at the beginning, we'll talk about it throughout, but ensuring that you have a vendor partner that aligns with the goals and the vision of your organization. And as you think about future planning, growth, or expansion, making sure that the partner that you've selected is able to grow and expand with you as you develop and grow within your own organization. Next, we'll talk about the single database. So this connects certainly to some of the data liquidity points, but it has become increasingly important to have an integrated system that allows you to have a single system for documentation across all care settings. So regardless of whether you're intaking a patient in the ED, admitting them to the floor, discharging them for rehab and follow-up in the outpatient clinic, and then managing to avoid readmissions over the course of care for that patient, you want all of that data in a single place in an integrated way to access to ensure that you have all of the most recent and relevant data as you're caring for your patients. Next, we have stable costs. Some may argue that that should be the very first cog of the wheel. It's incredibly important to manage costs and to have predictable costs over the term of your partnership with your EHR vendor. There are a lot of ways to be creative in the way that cost models are structured. There are subscription models that can help you to have predictable, even cost over the term of a relationship. It helps you to avoid unexpected expenses. Right now, there's a lot of fluctuating costs. Certainly, regulation drives a lot of it, where we're having downward pressure on margins within healthcare organizations. And being able to have predictable, stable costs is incredibly important in a vendor-partner relationship. Connected to cost, it's the right size cost. And this comes down not just to the dollars that you're spending, but the functionality that you're getting for the investment. And so this is one of the things that I get really excited to talk about with our partner organizations, because how do you know that you're maximizing the value of the investment that you've already made in your software? Chances are that you've implemented it along the way. You went through training and education. You may have a checkpoint, like a health check or an assessment along the way to determine how things are going. But how do you know that you're maximizing the investment that the organization has made? So we do a lot of discussion with our clients talking about the right size, right fit, right cost application. And we get a lot of really open and honest questions about, hey, if I have the lowest cost solution, is that going to have all the features that I need? If I have the highest cost solution, does that ensure I have the functionality that I need? And so we have that conversation a lot. And when you pull back a lot of the dollars, it's incredibly important to look at the functionality and the deliverables and the partnership elements for the mission and vision of the goal of your organization, both from an IT perspective, from a clinical perspective, and both operationally and financially too. And then finally, it's really important as you're looking at your vendor-partner relationship to look at the services and support that's offered and making sure that there is a depth and breadth of expertise in all areas to ensure that you have a fully optimized system today, but that you have a long-term partner that's going to ensure that you have the value proposition in a long-term partnership going forward. So these are all things that I think if we sit back, we would say, yes, these are all critical and they're table stakes. And I think the next step is the question, but truly, what does that look like for me today in my organization? What does the architecture look like? How would I evaluate my current partnership? What does my access to data look like? How much am I paying for it? Am I maximizing the value of my investment today, and how can I ensure that I do that going forward? So we'll keep that in mind as we flip ahead and we talk about the vendor partnership as you're developing that, perhaps enhancing it, perhaps replacing it, and we'll look at the pillars in the healthcare IT space today that are really important to consider. And I'll turn it over to Salman to talk us through those things.
Thank you, Allison. I think as we talk about the EHR vendor partnership, we have to recognize that organizations are still operating under certain administrative structures. So as we get into conversations, and it doesn't matter the size of the organization, we would typically be talking with folks who are over the clinical or ancillary applications, or folks who are overseeing the administrative or revenue cycle applications, or population health applications, or analytics applications. That tends to be the model for most of the organizations on how a CIO sort of creates this team. And for each one of these teams, the objectives could be fairly variable as they're talking to different EHR vendors. It could be a single vendor, it could be multiple vendors. And at a foundational level, I think most of the organizations, or most of some of these folks within these pillars, are trying to do one basic thing, which is right sizing, as Allison pointed out, and having single investments, or at least controlled investments, which allow them to be on a single platform. And so the way to go about it, at least in most of the organizations that I've come into contact with, is that they would have a list of all of the applications that they have in their health system today, whether it's clinical, rev cycle, pop health, or analytics, and they would go about saying, okay, well, we've got our acute care and critical care solutions from this person, and a surgical solution from this guy, and ED, we're getting it from here, and for content, we have partnership with this knowledge vendor or that knowledge vendor. I think at the foundational level, what most organizations are trying to do is have full accounting, at the very least, of all of the sources that provide input into their IT infrastructure. And for the most part, we see organizations wanting to make sure that they're investing in a single vendor relationship as much as possible within these pillars. Most organizations would also have that objective of having that single vendor relationship across all of these pillars. So they're looking for enterprise-wide solutions across clinical, ancillary, administrative, rev cycle, population health, and analytic solutions. Just getting a single vendor to provide all of these solutions is still foundational. That's essentially saying that if you're building a new home, your power source or your water source or your gas source is now through the same company. But that just essentially cuts out a lot of overhead, a lot of application rationalization can be achieved, but that in itself is not the end result that most organizations are trying to achieve in today's market. What they're looking for is also, in addition to the foundational value that they're getting from their relationships, is what is the value add that they're getting from these organizations or from the investments they've already made. And the value add is sometimes a combination of what the end user sees, or the CFO sees, or the CEO sees, or the market sees as happening within a healthcare system. And that's the sort of recognition that we talked about earlier with the HIMSS analytics model, or it could be through better patient engagement. How many times do you remember driving down an interstate and seeing billboards from healthcare systems that talk about their engagement with their patients or their ability to turn patient outcomes? So a lot of the value add is still expressed in terms of non-financial terms, but in some cases the value add, for instance, an organization that can attract providers to come in and have 100% mobile workflows for certain areas or certain specialties, or allow them to more advanced use of voice recognition or virtual assistants. Those are the kind of things that may seem like not necessarily significant investments, but on top of very solid foundation, those are the kind of investments that allow organizations to retain more clinicians, retain more patients in their network, and continue to grow their network. And the same is true across all of these 4 pillars. Every one of the leaders, whether it's the director of clinical applications or director of revenue cycle applications, is interested in showing how some of these things can be improved or added into the organization. And I think the layer that excites us the most as we're working with our clients, it is essentially figuring out for each one of these pillars, what are some of the outcomes that you can prove to your own organization meaning your own IT team, your analysts, the folks who used to be bedside nurses and PAs or pharm techs or pharmacists who have now joined the clinical IT team. What are the things that they can tell themselves that they are proud of? The fact that they built a workflow that allowed better detection and surveillance for a certain disease state, which allowed them to treat patients faster in a more standardized way. The things that they did in order to prevent more harm related to overprescription of whether it's opioids or antibiotics. And those are the sort of things that organizations do not have the liberty or time to pay a whole lot of attention to. And that's where, again, a relationship with an EHR vendor, which allows them to focus on each one of these tiers, not just on the foundational or the value add or the clinical outcomes or the outcomes tier itself, but allows them to focus on all of these aspects, is the right vendor that you want to have your long-term relationship with. And that sort of goes back to Allison's point about the right size cost. So having this sort of a framework allows you to think through, do I have the right foundation? What are some of the things that I need to invest in now to have a value add for my organization, and so on and so forth. Before I move on, Allison, I'll look to you, see if you wanted to add anything in this sort of a model or framework.
Sure. I would add the thought of where this starts and how it comes into play throughout a partnership over time. I think if you're in a position where you're looking for a new EHR vendor partner, these are all incredibly important pillars that you need to be having discussions around. And if you're in an existing relationship with no intent to change your partnership, then that's great. I think that you still need to elevate these discussions to make sure that you're talking about outcomes in each of these areas. And then the last piece is really, how do you know when you've won, or how do you know when you're successful? And I would encourage you, if you're not already within your organization, to really look at what your outcomes and what your goals are in each of these pillars. I think that we would all agree these are foundational. In your organization, you may have a few more, you may have a few less, but what are the measurable outcomes that you want to achieve? And make sure that you understand that as an organization, but then make sure that you're coming around the table with your EHR partner and talking about what those anticipated outcomes are, because oftentimes the EHR will have a feature functionality to support it, but then what are the extra effort? Who are the people that you need to come alongside to help you develop that strategy, to help you create measurable and metrics for success? And then what are the checkpoints by which you understand whether you've been successful in each of those areas? So in addition to all the things Salman said, really putting that into tactical, actionable next steps, I think is really important for success in that adoption and utilization journey.
That's right. And, you know, as we switch to sort of a slightly different stream of thoughts, we've talked about how traditional IT organizations are structured. There's teams that are looking at clinical applications, revenue cycle applications, analytics, and so on and so forth. What that has done, in my opinion at least, over a period of time, that it has sort of created a parallel sort of a hierarchy within organizations, which may not necessarily align with the business of healthcare itself. And I could be wrong, and my intention is not to say that it's correct, incorrect, or be derogatory towards that. But I do want us to sort of focus on the idea that healthcare organizations exist to provide services across various service lines within the kind of scope they have for their specialties within those service lines. That idea is important because I think it allows IT organizations to sort of move away from these structures that have come up in the last 5 to 7 years, which force teams to sort of be focused on clinical or financial or pop health or analytics applications, but be more closely aligned to a service line. And a service line being an idea where a hospital leader or a healthcare system leader knows exactly what kind of services are provided in the health system. So these would typically fall into any of these 9 categories for ambulatory or outpatient services, hospital-based services, patient services that could be initiated by a provider in an inpatient setting or an outpatient setting or a home setting or a long-term acute care setting. But the patient service is then delivered by a range of specialties or therapists. And then there are specific services for ED and urgent care, and we continue to see expansion of the urgent care model as well as freestanding EDs in certain states. That in itself is a service line. And so are things like perioperative services. Instead of calling them just surgical specialties, these are perioperative services, including the pre-surgical pathways for screening and consultation with different specialists before getting in for whether it's a same-day or elective procedure, and then followed up by rehabilitation services or post-surgical services. These ideas are still embedded into every single thing that IT organizations do, but they're not expressed with such an intent that says clinical, revenue cycle, and population health and analytics are functions that support each one of these service lines. Because what is the population if it is not a population of individuals that comes into contact with the healthcare system asking for a service now or potentially in the future, or maybe a population that you want not to come into contact with the service. So it may be your behavioral health service where you're trying to do more preventative programs within the community with the idea that you do not want people to hit a stage where they do require inpatient or other services. The idea, Allscripts at least, is trying to sort of work very closely with our clients of, again, it doesn't matter what size and complexity they have, is recognize that each one of these service lines themselves represent an opportunity for organizations to standardize their operation across 3 very simple ideas. And this may be very explicitly understood by most organizations, but I don't know if it is universally accepted or practiced, and that is that each one of the service lines healthcare system may have. The first thing for an IT organization is to really think about the workflows. And by workflows, a lot of organizations do not have the full or in detail constructs of, is this a workflow for a provider or a workflow for a nurse or a workflow for an application? No, I mean, the workflows have to be expressed in terms of anyone getting in contact with the service that you provide in a healthcare system. So take that first point of contact to the last point of contact, that constitutes a workflow. That's how patients who need surgical services, how do they get in? How do they get referred in? How does the surgeon see them? What sort of steps are required for pre-admit testing or for preoperative testing, and so on and so forth. And with those steps, we have the full understanding of what needs to be built inside of the EMR. And a lot of organizations do it, but they do not do it, again, as I said, with an express purpose of showing what is the workflow that drives the build within the application. A lot of IT organizations have very strong analysts or team members who could do build of any level of detail or complexity, but I think it's that consistency of having a good workflow diagram or document driving some of the build that's missing sometimes. And the third thing that is missing sometimes is not necessarily not a focus on outcomes, but building outcomes attainment as a byproduct of any project that you do. And it's easier said than done. People still have limited time and resources. It is not always possible to create a net new data governance model or a data strategy which allows you to implement and automatically turn on measurement. But I think the idea is not lost on a lot of the audience that's with us today, that similar to the blockchain technology that is being applied across other industries, the same could be applied into healthcare with the use of EHR solutions, and not just EHR solutions, but any electronic or digital solutions which measure start times, stop times, time spent within an application, as well as other domains of a particular process step. It is possible for us to go from a standard definition of a single workflow and then a measurement model which an organization can build into their analytics tool, which are so readily available these days, to start saying things like, for my workflow, for a patient appointment and scheduling, this is how we measure how scheduling an appointment and scheduling is done. And also look at, by using all of the functions in the EHR and by measuring all these process steps, are all of these things important to our organization to report at a macro level? And they may or may not be, but you could start looking at models where organizations do now start out with things within the scope of a service line or a specialty which they can all agree on. And they could say that if we're talking about a hospital-based service, maybe what is important to us is an average length of stay for a specific DRG group and maybe some specific readmission rates. And although those words keep getting used again and again and again, I think the opportunity with the EHR is not necessarily an exercise in reporting to CMS, participating in an ACO program, or doing reporting just for the sake of reporting, but trying to see if these things are core and sort of close to the success of this specialty or this service. What is our true baseline today? What can we do within the new implementation of a new EHR or improvement to an EHR through an optimization program, whether it's fewer clicks, whether it's cleaner processes, whether it's removal of other applications that people need to go to find data, whatever those things may be, have your IT teams more focused on finding out how are things going to get better, and leverage what your EHR vendors have learned over the last 5, 10, 15, 20 years with respect to how some of the clinical pathways could be set up. And there's always room for improvement. We're always learning from the industry. We're always learning from the researchers. And you know, a big part of the new EHR age is to find rapid ways of finding those opportunities, building them back into your implementation work streams or your agile sprints that you may run for improving your service line workflows, and then making sure that go live is not necessarily the end point of that improvement process, but you follow it up with intent to measure the performance for a period of time and go back and see we did put in this new pathway for these kinds of patients. Now let us keep an eye on how many times are those pathways used by what kind of providers for what kind of patients, and live inside of that data to become more focused on those kinds of results that you want to achieve from those implementations. And maybe to that effect, you know, while I sort of look to Allison to add to what I described as this workflow-oriented design, this understanding of you need to start with the recognition that the IT structures do not sometimes align with the service line concept within healthcare systems. And just because we have these traditional clinical rev cycle or ancillary application teams doesn't mean that they cannot be more closely aligned with the 9 service lines that I talked about earlier. Because as we do that, we then start focusing on the end-to-end and not just points in time. And here are some of the examples from some of the recent implementations that we've done and the feedback that we've gotten from some of the leaders in those organizations. So, Allison, I'll turn it to you to sort of talk from here.
Sure, thanks. I would add, as we hang out on this slide for a few minutes, I think that Dr. Walker talks a lot about what happens next. So I think that, you know, we can look at definitive points in time where we implement something or we build an interface to something or we upgrade something or activate. And I think that the relevant question is always what happens next. And I'll share a story about one of our partners and clients that I've chatted with recently about how do we ensure this continual process of improvement, because there are things like Salman said that may be specific to the IT application that sit outside of just IT, or maybe it is just clinical or just financial or just operational. And so we talked about the strategy of bringing together key stakeholders in each of the different service lines and in each of the different areas where they're looking for that continual improvement. And I think it was a really raw and interesting conversation with this client, and they said, listen, we don't know what we don't know. And I said, that's a really interesting statement, and I would actually say it back to you. And I think that if we come to the table and share the things that we both know, it helps us understand where we're doing really well together and where our opportunities are to do things differently and better. And so we're putting together a plan where we really identify the things that are important to their organization. There are a ton of buzzwords and a ton of topics that many of you are likely dealing with in your organization, things like utilization and occupancy rates and increasing revenue capture and decreasing your total operating spend and patient access improvement and average length of stay reduction and provider and clinician burnout. These are all things that we talked about, and we said, listen, let's put a plan together for how we make sure that we understand how the technology supports you from a feature and functionality perspective. Let's make sure that it's there. And then let's figure out who the people are that we bring alongside to ensure that we're meeting these goals as the organization. So I think Dr. Walker's statement is really relevant in how we look always to what's next as we work through that organization-vendor partnership. And then I think Steve's comments around ensuring that it's not just the software, it's not just the hardware, it's not just the training, but it's really a partnership. I think that brings us into the next conversation a little bit around support and services, because singularly, none of those things are going to create a successful partnership. And so I think it's been an interesting shift in our industry for the things that are more relevant and more common now and things that have become best practices. So we'll use that to launch into talking a little bit about support and services and really how those things are evolving within our industry. So what you'll see is we have a couple of different pillars and triangles of support and services, and we really worked through things that, in our opinion, are traditional, the things that are, the lion's share of relationships for EHR vendors and healthcare organizations, and then the things that have become a new standard and things that are becoming more common. So we'll talk through these a little bit and would certainly be interested in the thoughts that you have as we talk through each of them. I think that the traditional model is certainly, I have an EHR system because I have to, and I'm trying to find the value in it, and I'm trying to maximize the value in it. And likely right now we see a lot of support for the defects and the bugs and the fixes. And so what we're doing constantly is having conversations about how we elevate out of that space and how we find new standards and best practices to become more commonplace in the organization. So the next one talks a lot about technology. And so from an infrastructure perspective, looking at how you're maintaining that infrastructure and what are the requirements and the uplifts that are dictated by hardware or by other software providers that may not be your EHR vendor, but maybe it has something to do with your operating system and upgrades that have to happen for you to maintain and be current with your operating system. And when you have a partner who provides that hosting technology, it really takes a lot of that responsibility away from you, places it on your partner, and creates a stronger partnership as you're then holding each other accountable to providing the technology and infrastructure support for your organization. That's become more of a new standard. The next few are really becoming more common. One is staff augmentation or outsourcing of staff. When I say that, I think that there is an instant gravitation to thinking that you have an entire replacement of an incredible team within your organization. Really, this can look and feel a lot of different ways, and I think connects these two pillars together between the staff augmentation and the help desk. It could be as simple as a single body that you brought in to really help provide a specific area of expertise within your organization. It could be access for help desk, whether that's application help desk or clinical help desk for your clinicians or your end users. Or it could really be looking at the broader outsourcing of an IT team to be more efficient and more effective in how you're leveraging the people and the time and the space that they're working in. So that's becoming a lot more common. We get a lot of questions about that, a lot of what does an organization look like that's staffed properly? Or this is the application I'm running. Do we look right? Are we right-sized and right-fitted for the size of our organization and the application that we're supporting? We have a lot of partnerships with clients who do not run our core EHR and have really interesting insights into what that looks like. So a lot of conversations right now around the support and services from a people perspective within the organization. What is a little more atypical, but I do think is moving to become more common, especially in maybe the space that is the 50 to 100 to 150 bed acute organizations, is this concept of EHR as a service. We've seen it existing in the ambulatory space a bit longer than we have in the acute space, but what does that look like and how do you access it? We talked about the predictability of cost earlier, talked about the right size, right fit for the organization. So I do think we're going to see more of that in our landscape as we move ahead, certainly doing a lot of what was done in the ambulatory space and being able to offer that in the acute space as a service as well. And then finally, this concept of value-added services, and we talked a lot about the business process improvement or the continual process improvement earlier. These are the things that there has to be open dialogue about as you're building or strengthening your partner-vendor relationship, and understanding, helping your vendor and partner understand what's important to your organization and what your goals and how you'll achieve outcomes is incredibly important. But I think most importantly to all of this is a few things. One is that none of these pillars can stand on their own. They're all incredibly important together as you look at the strategy of your organization. And the other is that every single one of these drives an outcome, whether it's clinical or operational or financial or technological. There are outcomes that each one of these areas are driving. And so as you think back about the topics that we've talked about today, whether it's understanding that workflow drives everything, or that adoption and utilization begins way before day one, or having a workflow-centered design is incredibly important for your organization, or bringing the stakeholders outside of just the IT space and the clinical space to help us really understand what the goals are of the organization. Just know that a successful vendor partnership relationship takes all of those things into account, understands the strategies, and helps to develop the outcomes, and then work together through a partnership to achieve the outcomes that are intended for your organization. So as we move into hopefully a time of a bit of discussion and questions, would certainly welcome thoughts and feedback as you talk about and think about and share the relevance of adoption and utilization of EHRs within your organization and your vendor partnerships that you're leveraging to help you do it. So with that, I'll turn it back over to Brian, and thank you all again for your time.
Thank you, Dr. Nakvi and Allison, for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard. We'll try to get through as many questions as we can. So we've got a couple of great questions coming in here, and we'll go ahead and get started with this one. So what are the common outcomes where healthcare organizations are focusing their efforts?
That's a good question.
I could probably,
I'll take
yeah, you will take it. Yes, go ahead.
I'll start, and then I'll pitch it to you. We'll tag team it. So I think it's a really good question, and really we could probably spend another hour talking about this. And so I'll tell Salman he has maybe a 2-minute cap to talk about the exciting things he's seeing, especially from the clinical and the services side. But I think a lot of outcomes, we've talked about this a bit today, a lot of the outcomes really come down to the broader organizational strategies. And I think right now a lot of them are centered around the concept of payment for value instead of the payment for service, and how we do that differently and better together. A lot of that around some of the clinical quality initiatives that are happening within your organizations. And then I think beyond that, it's really looking at things around utilization. And by that, I mean things like occupancy, because you're looking at what's driving the bottom line for the organization, whether it's within the walls of the hospital or how you're managing that patient through a continuum of care is dictated by different payment models. And so those are some of the key areas where I think we're having a lot of conversation right now. And Salman would certainly look to you for some examples and measurable outcomes for success.
Yeah, I think organizations are very, diverse in their approach and outcomes. So there could be small organizations doing big things and big organizations doing big things. But I think more and more organizations are starting to see the full ecosystem in which outcomes live and get measured and get reported on. So it may be that there is an individual who's come into a small organization and he wants to focus a lot on improving antimicrobial stewardship, for instance, and he would work very closely with the IT team. And again, in a lot of cases, once the project is said and done, it may become a presentation for audience at Becker's or at HIMSS, and it would be a conversation about, hey, this was something that I worked on with the IT team, and I was able to leverage the solutions. I think what gets lost in some of these conversations also is the fact that no matter how the outcome was achieved, it was an outcome that showed another proof point to the whole healthcare industry that there's potential within some process that happens today and in tweaking that process or measuring that process. And in some cases, we've just learned from healthcare organizations the effect of measuring on behaviors. So, and it could be simple things like we've created an order set for you because you've been asking for it for a long time, and it may be more disease specific. But once you start looking at how many times patients who had that particular diagnosis were treated using an order set and just sharing that data back with the team of hospitalists has a profound impact on how they use technology. So they may not even be looking or maybe interested in driving certain behaviors, but the liquidity of data, as Allison pointed out earlier, and its ability to influence behavior, that is the more exciting thing as EHRs become more widely adopted across the organizations. I still think that there's a little bit of a turf thing that goes on, and that's, I think, a positive thing. I wouldn't discourage anyone who says, oh, this is my idea, or this is my idea, or this is my intellectual thought process. All of that is fair. If you want to thank the IT team for it, if you want to thank your analytics team for it, or if you want to work closely with the enterprise data warehouse, to us, none of that matters. What matters is that there's organizations, a lot of them, a large majority of organizations, taking their lead, finding problems that they want to solve, and going about it.
Great, thank you both. And I think this next question sort of builds on this discussion around outcomes. So I'm wondering if we can't dig a little deeper there. This attendee would like to know, so where are organizations being successful regarding outcomes?
Well, in some cases, they're successful when most of the clinical process, or at least most of the patient workflow, is contained within a single sort of an application and doesn't require external data sources or manual entry of data through auditors or data from, let's say, the claims, so on and so forth. So we are seeing a lot of improvements based on the data that lives within hospital-based healthcare systems, EHRs, related to early detection and diagnosis. I mean, that continues to be a biggest driver of EHR adoption for emergency departments, for patients coming in with signs and symptoms of pneumonia or exacerbation of COPD, or symptoms that are indicative of sepsis, but it's too early to call. And therefore, all of these early recognition systems, which use triggers built within any EHR, are still the areas where people are continuing to see more and more improvements. I think there's also widespread use of more comprehensive surveillance systems that keep an eye on the patient, not just for an initial trigger event, but for anything that could happen to a patient on a particular pathway. And this is not so much like the core measure, sort of a edict of before discharge, make sure you've done this, but it's throughout the patient's stay. Make sure that if the patient was put on a sepsis pathway, for instance, if there is degradation of physiological functions, have the system be smart enough to alert and be able to change or provide recommendations based on the evidence that already exists. So specifically, we are seeing a lot of outcomes work where it is focused on very early detection of diseases and putting more mechanisms in place to identify degradation or deterioration of patients.
Thank you, Dr. Naqvi. And this next question here, the attendee would like to know, what are your thoughts about different EMRs communicating or interfacing better in the future? Would either of you like to weigh in there?
Yeah, I'll start. I'll start and share some thoughts. I think that the future is probably coming quicker than we realize, and it's a relevant question because I think we've made a lot of progress and leaps and bounds, truly. I think as our industry sees a lot more growth through expansion and acquisition, this question becomes more relevant. And so when you're talking about connecting different EHRs together, how do they communicate or how do they interface better? We actually have a lot of client partners who we serve in this capacity today. They may not use a core EHR of ours, but I think that there are systems where you have a community-connected model that helps you to bring aggregated data to the point of care through care coordination, patient engagement, connectivity, data aggregation, pulls all of those things together so that your clinicians at the point of care can really help to manage the care transitions and coordinate care teams across a community that may be using disparate EHR systems. And so my thoughts are that it will continue to improve. I am excited to say that we are doing that incredibly well with many of our partners today, and I think that we'll continue to see the power through connecting data in ways that help to empower care throughout communities that are on disparate systems.
And I would just add to that Allison is absolutely right. The question of connecting across EHR platforms is contextual. It is context-based based on if your organization has a certain network of connected solutions that it now wants to expose to the end users, or if you're more altruistic or if you're taking a policy position and saying, hey, it's great that patients coming within a certain network have the ability to get connected across EHRs, but what is the plan or what is the strategy that EHR organizations are executing so that there's a sort of a more universal accessibility for the data that lives in an EMR? And I think in both of those questions, the industry has made significant strides, as Allison pointed out. For the first one, which is more contextual, I would sort of absolutely second what Allison said. And for the more sort of policy-oriented, I think, with CCDA and FHIR-enabled APIs, I think the standards are moving to a place where it becomes easier for organizations to work together. But I don't necessarily know if there is a policy goal at the end of this conversation that everyone is already on the same page on, and whether it's at a local level or at a state level or at a federal level. So we're just as involved or engaged or interested in sort of finding out where all of these capabilities meet the policy that's being driven from the rest of the stakeholders.
Thank you. And we are about out of time here, so this will be our last question. What role do you see accountable leadership playing in achieving desired outcomes from EHR investments?
I love that one. I think that from an accountable leadership perspective, it's making sure that you understand the different spaces in which the goals and strategies and outcomes exist in the organization, and then leveraging the key players in each of those areas as stakeholders as a part of the process. So what role do I see as being important? I think it depends on the outcome. One of the things that we've done with a lot of our partners and clients is establishing this concept of an outcomes board. And Salman has been critical in playing roles in the success of those outcomes boards, where we do bring executives, whether it's the CFO or the controller or a team from procurement or the CNO or the CMO, the COO, bringing in folks from a leadership perspective that have visibility into the strategies to really help their buy-in and moving those initiatives forward. And I think that when they see the work that the teams are doing within their organization to move them forward, it really helps to connect the vision from a singular focus within a singular area like operations or finances or clinicals, and then stretches that across the organization to recognize how one outcome may largely impact another one. So I think from a people role perspective, it could be varied depending on the outcome and the strategy. From an importance perspective, it's incredibly important. So really good question and important to be mindful of as those strategies are coming together across your organization to support the investment that you've made in the EHR.
And if I could just add one more thing to that is I think one of the things that accountable leaders can do is liberate decision-making and start thinking of the EHR vendors not necessarily just as people who come in looking for your business, but people who should have, can have, and will have skin in the game for delivering those outcomes that are integral to your success. And by liberating, I mean specifically asking everyone in the organization, and all of us live in a matrix world where we all share common goals and responsibilities, is for leaders and organizations to include people who are part of this ecosystem, of this network of partnership with EHRs and other organizations, and have them be responsible for delivering results as if they were part of their own teams.
Absolutely.
Well, thank you both, and that's all the time we have for today. Thanks again, Dr. Naqvi and Allison, for your fantastic presentation, and thanks to Allscripts for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thank you.